Today we're going to talk about the special senses. That information can be found in chapters 10 and 46 of your textbook. The first couple of slides are the combining forms and the prefixes and suffixes for the eye, and then the combining forms for the ear. Any change that we detect in our environment, whether it be internal or external, is called a stimulus. We respond to changes in the outside world, so for instance, light, loud noises, bitter or sweet food, based on signals from the sensory receptors. We also respond to changes inside the body, such as changes in blood pressure or changes in body temperature. Whether they're inside or outside the body, sensory receptors receive information and transmit signals to the central nervous system. The central nervous system then signals effectors to make appropriate adjustments. Sensory receptors may be a specialized ending of a sensory or afferent neuron, or may consist of one or more specialized cells in close contact with a sensory neuron. A receptor absorbs energy from the stimulus and then transduces or converts the energy of the stimulus into electrical signals. Sensory receptors make up complex sense organs, which are the eyes, ears, nose, and taste buds. The first step in sensory processing is that a sensory receptor absorbs a small amount of energy from a stimulus in the environment. The second step is energy transduction, and that is when the sensory receptor converts the energy of the stimulus into electrical energy. The third step is a change in membrane potential occurs and produces a receptor potential. Receptor potential is a depolarization or hyperpolarization of the membrane. A receptor potential is a guided response, which means that the extent of change depends on the energy of the stimulus. The action potentials generated by seeing a dog or tasting a cookie are the same. Our ability to distinguish between these stimuli depends on both the sensory receptor and the brain. The fourth step in sensory processing is the receptor potential may generate action potentials in sensory neurons. Finally, the sensory neuron transmits signals to the central nervous system where integration takes place. Sensory adaptation refers to a decrease in frequency of action potentials in a sensory neuron even though the stimulus is maintained. For example, you may have noticed how quickly you adapt to an unpleasant odor. After a few minutes, you hardly notice it. Many sensory receptors do not continue to respond at the initial rate, even if the stimulus continues at the same intensity. Sensory perception is the process of selecting, interpreting, and organizing sensory information. It is constructed by comparing our sensory experience with memories of past experiences. The brain interprets sensations by converting them into perceptions of the stimuli received by our sensory receptors. We construct sensory perceptions by comparing our sensory experience with our memories of past experiences. For example, if you grew up with dogs, your perception of a German Shepherd may be very different from someone who did not grow up with dogs. We receive information about the environment in various energy forms. Sensory receptors transduce or convert these types of energy into electrical energy that can result in an action potential. Each kind of sensory receptor is especially sensitive to one particular form of energy. So we have photoreceptors, which are located in the retina of the eye, and they respond to visible wavelengths of light. Mechanoreceptors are activated when they change shape as a result of being pushed or pulled. They convert mechanical forces such as touch, pressure, or stretching into electrical signals. Chemoreceptors transduce the energy of certain chemical compounds. Thermoreceptors respond to thermal energy. Nociceptors are pain receptors. They respond to stimuli that could damage the body. Vision is our dominant and most refined sense. The eye is the organ of sight. External structures protect the eye. Tears flow through lacrimal glands. They pass out through the lacrimal ducts and lubricate the surface of the eye. Tears keep the eye moist and free of dust and minute objects. The eyeball is formed by 3 layers of tissue: the fibrous sclera and cornea, the choroid layer, and the retina. A thin ciliary body, the iris, and inner fluid-filled cavities make up the rest of the structure. The sclera is the white layer of the eye that covers the outside of the eyeball. The cornea is a transparent part of the eye that covers the iris and the pupil and allows for light to enter. The lens is a biconvex structure behind the iris. It focuses the light rays onto the retina. The iris is the colored tissue at the front of the eye that contains the pupil in the center. The iris helps control the size of the pupil by dilating or constricting to allow more or less light into the eye. The pupil is the black opening at the center of the iris that controls how much light enters the eye. The retina is the innermost part of the eyeball. It contains receptors, rods and cones that convert light into nerve impulses that travel to the brain where the impulses are processed. The cones are responsible for color vision and vision during daylight. The rods are responsible mainly for vision in dim light or in darkness. Next is the optic nerve. That is the nerve that receives messages from the retina and carries it to the brain. Positioning the eyeballs is the function of the coordinated and precise actions of 6 extrinsic muscles. The eye has the power to accommodate, or the ability to change focus for near or far vision by changing the shape of the lens. Accommodation is a function of the ciliary muscle. Light is converted into neural signals that transmit information about environmental stimuli into pictures in the brain due to rhodopsin, which is the pigment in the rod cells and some cone cells that is responsible for the ability to see. When exposed to light, this breaks down into a large protein called opsin and retinol, which is a derivative of vitamin A. So the visual pathway, light passes through the cornea, through the aqueous humor, which is the area between the cornea and the lens that is filled with a watery substance, then through the lens, then through the vitreous humor, which is the area between the lens and the retina that is filled with a viscous fluid. After that, the image forms on the photoreceptor cells in the retina, which signals bipolar cells. Bipolar cells are where photoreceptors, the rods and cones, synapse. The bipolar cells signal the ganglion cells, which is where the bipolar cells make synaptic contact. The axons of the ganglion cells extend across the surface of the retina and unite to form the optic nerve. After that, the optic nerve transmits signals to the thalamus, which signals the primary visual cortex, which is the region of the brain that receives, integrates, and processes visual information relayed from the retina. And then the integration by visual areas in the brain in the cerebral cortex occurs. Neurobiologists have not yet discovered all of the mechanisms by which the brain makes sense out of visual information. We do know that a large part of the association areas of the cerebrum is involved in integrating visual input. Some age-related changes to the eye are a decreased number of receptors in the retina. So the eyes adjust more slowly to changes in light. It becomes difficult to read small print. The lens becomes cloudy and opaque. The lens becomes less flexible. When that occurs, it's unable to properly focus light on the retina. And then there's a decrease in tear production, which causes the eyes to become dry. Some common disorders of the eye. First, conjunctivitis, which is infection and inflammation of the eyelid. Signs and symptoms include red, itchy, teary eyes, white or yellow discharge from the eye. Guidelines for caring for someone with conjunctivitis include washing hands before and after providing care, and encouraging the client to avoid rubbing or touching the eye. Next is cataracts, and that occurs when the lens becomes cloudy, preventing light from entering into the eye. This decreases vision. It's treated by surgery to remove and replace the lens with an artificial one. Guidelines for caring for someone with cataracts includes providing extra light in the room, not sitting the patient facing the window or bright sun, encouraging independence, and assisting with ADLs as appropriate. Next is glaucoma, which is increased pressure inside the eye. It can lead to blindness if not treated. Signs and symptoms of glaucoma include decreased vision, nausea and vomiting, seeing a halo around lights, and blurred vision. And finally, age-related macular degeneration, which occurs when receptors in the center of the retina are destroyed. The resident can only see the periphery of the field of sight. Some guidelines for caring for a resident with a vision impairment include encourage the use of glasses, check glasses daily to ensure that they are clean, knock before entering the client's room, identify yourself when you enter the room, announce to the client when you are leaving the room, do not move the client's furniture, and using numbers on a clock to tell a client where food is located on the plate. Some things to report to the RN related to the eye include drainage from the eyes, resident complaints of dryness, redness in or around the eyes, and glasses that are broken or do not fit properly. The ear is responsible for hearing and balance. The pinna is the part of the outer ear that projects from the side of the head and surrounds the ear canal. The ear canal is more formally called the external auditory meatus. The outer ear consists of the tympanic membrane and earwax. The tympanic membrane separates the middle ear from the external ear. Incoming sounds cause this flexible membrane to vibrate, transmitting sound waves into the middle ear. The middle ear is responsible for equalizing air pressure and consists of three small bones, the malleus, the incus, and the stapes. The middle ear is a small, moist cavity in the temporal bone containing air and three small bones. At the rear of the cavity, the middle ear opens into the mastoid process of the temporal bone. This area is filled with air spaces that communicate with the middle ear and help equalize pressure. Under normal circumstances, the air pressure is equalized on the two sides of the tympanic membrane by the eustachian tube. This tube connects the middle ear and the nasopharynx. Bacteria from the throat can pass through the eustachian tube, leading to ear infection. The tiny bones of the middle ear form a chain from the tympanic membrane to the oval window, which is a small membrane between the middle and inner ears. Sound waves cause vibrations of the tympanic membrane. The auditory ossicles act as levers that help amplify the vibrations. Next, we have the inner ear, which consists of the cochlea and semicircular canals. The inner ear contains mechanoreceptors that convert sound waves to nerve impulses. This part of the ear also contains receptors that enable us to maintain our equilibrium or balance. The inner ear lies inside the temporal bone. It is a bony labyrinth composed of three compartments: the vestibule, the cochlea, which contains receptors for hearing, and the semicircular canal, which helps us keep our balance. So the physiology of hearing: sound waves enter the external auditory meatus. The tympanic membrane vibrates. The malleus, the incus, and the stapes amplify vibrations. The oval window, which is a small membrane between the middle and inner ear, vibrates. The vibrations are conducted through perilymph, which is just a type of fluid. The vibrations are transmitted through endolymph. Next, the basilar membrane vibrates, and that membrane separates the cochlear duct from the tympanic canal. Hair cells in the organ of Corti are then stimulated. The organ of Corti is found in the cochlea. It contains sensory cells that respond to sound waves by stimulating the cochlear nerve. And then the cochlear nerve transmits impulses to the cerebrum in the brain. So equilibrium. The vestibule and semicircular canals contain receptor cells that transmit information about the position of the body. So the vestibule is the bony cavity that harbors the soft tissue part of the labyrinth, which is part of the inner ear. Inside the vestibule, the membranous labyrinth is divided into the saccule and utricle. These chambers house gravity detectors in the form of small calcium carbonate earstones called otoliths. Each receptor has a large group of hair cells surrounded at the tips by a gelatinous mass called the cupula. Information about turning movements, referred to as angular acceleration, is provided by the 3 semicircular canals. Each canal, a hollow ring connected within the utricle, lies at right angles to the other 2 and is filled with endolymph, which is a type of fluid. A small bulb-like enlargement called an ampulla is located at one of the openings of each canal into the utricle. Within each ampulla lies a clump of hair cells called a crista. These hair cells are similar to the groups of hair cells in the utricle and saccule, but no otoliths are present. The hair cells of the crista are stimulated by movements of endolymph in the canals. When the head is turned, there is a lag in the movement of the fluid within the canals. The hair cells move in relation to the fluid and are stimulated by this flow. This stimulation causes an awareness of rotation. 1 in 3 adults over 65 have hearing loss. Hearing loss is gradual, so many individuals do not notice it at first. So as people age, the tympanic membrane becomes stiff. The 3 small bones don't vibrate as easily, and the sensory receptors in the cochlea decrease. These 3 things result in decreased hearing. Some common disorders of the ear are otitis media, which is infection of the middle ear. Signs and symptoms include ear pain, fever, difficulty hearing, and discharge from the ear. Meniere's disease, which is a disease of the inner ear that causes dizziness, ringing in the ears, temporary hearing loss, nausea, and vomiting. And finally, deafness, which is the inability to hear. Conductive hearing loss occurs when sound waves are prevented from reaching the receptors in the cochlea. Sensory neural hearing loss is when the receptors are unable to transmit nerve impulses or to receive stimuli. Hearing aids are battery-operated devices that are used to amplify sound. They are very expensive. Some guidelines for caring for hearing aids include handle with care, turn off when not in use, store in a labeled container in a cool, dry place, check batteries frequently, do not get batteries wet, and have the client remove their hearing aid before bathing, showering, or shampooing hair. Some guidelines for caring for a resident with hearing impairment include reduce or eliminate background noise, encourage the resident to wear his or her hearing aid, check the batteries for hearing aids and make sure they're functional, face the resident when speaking, use a notepad to write out important directions, and consider sign language if appropriate. Some things to report to the nurse regarding the ear are discharge from the ear, complaints of difficulty hearing, complaints of ear pain, dead hearing aid batteries, or hearing aids that do not function. So, olfaction is the sense of smell. Chemoreceptors allow us to detect chemical substances in the air and in food and water. When specific chemical substances bind with chemoreceptors, a series of chemical events takes place, leading to changes in membrane permeability. If the membrane is sufficiently depolarized, action potentials are generated in sensory neurons. Unlike most neurons, both taste and smell receptors are continuously generated. The chemoreceptor cells in the olfactory epithelium are stimulated by odorants, which are chemical substances that can be smelled. Odorants dissolve in the mucus on the surface of the olfactory epithelium. Fun fact, humans can perceive about 10,000 different smells. Gustation is the sense of taste. Taste is the job of taste buds on the tongue and various parts of the mouth. Each of the thousands of taste buds is an oval epithelial capsule containing about 100 taste receptor cells interspersed with supporting cells. The taste receptors detect chemical substances dissolved in saliva. The 5 main tastes that are recognized are sweet, sour, salty, bitter, and umami. Umami is the Japanese word for delicious. It is the taste responsible for the savory flavor of soy sauce, anchovies, and certain aged cheese and seafood. The amino acid glutamate triggers the taste. In sodium salt form, which we know as MSG, it's used to flavor foods. The 3 cranial nerves, the facial cranial nerve, the glossopharyngeal cranial nerve, and the vagus nerve, transport impulses from the taste bud to the medulla. Information is then transmitted to the thalamus and onto the gustatory area in the parietal lobe. General senses are the receptors that respond to touch, pressure, vibration, pain, changes in temperature, and muscle stretch. Most of these receptors are mechanical receptors. Those that sense pain are nociceptors. They're widely distributed through tactile receptors are located in the skin. Thermoreceptors are free nerve endings that allow us to detect temperature changes. Widely distributed throughout the body, thermoreceptors are especially concentrated in the lips and mouth. Thermoreceptors in the hypothalamus detect internal change in temperature and receive and integrate information from thermoreceptors on the body surface. The hypothalamus then initiates homeostatic mechanisms that ensure a constant body temperature. Nociceptors are pain receptors. There are several types that have been identified. Thermonociceptors respond to temperature extremes. Mechanical nociceptors respond to strong tactile stimuli. Stimulation of nociceptors does not always result in the perception of pain. We feel pain when information from the nociceptor reaches the brain as it is interpreted. When stimulated, nociceptors transmit signals through sensory neurons to interneurons in the spinal cord. The sensory neurons release the neurotransmitter glutamate and several other substances, including substance P, which triggers an inflammatory response by dilating neighboring blood vessels. This leads to edema, mast cell release, and histamine activation. These substances stimulate neurons in the spinal cord to transmit pain signals to the brain. The spinothalamic tract is the principal pain pathway which transmits signals to the thalamus where pain perception begins. From the thalamus, impulses are sent into the parietal lobes in the limbic system. The emotional aspects of pain are processed in the limbic system. When signals reach the cerebrum, the individual becomes fully aware of pain and can evaluate the situation. Endorphins, such as beta endorphin, inhibit the release of substance P, thus decreasing the transmission of pain signals up the spinal cord. The brain locates pain on the basis of past experience. Generally, pain at the body surface is accurately projected back to the injured area. For example, when you step on a nail, your brain perceives the pain and projects it back to the injured foot. Phantom pain occurs because when the severed nerve is stimulated, it sends a message back to the brain, and the brain remembers the nerve as it originally was, which is connected to the limb before it was missing. Nociceptors in most internal organs are not easily activated. Pain is sometimes not projected back to the organ that is stimulated. Instead, it is referred to an area just under the skin that may be some distance from the organ involved. The area to which the pain is referred generally is connected to nerve fibers from the same level of the spinal cord as the organ involved. You may have observed that rubbing the skin around an injury or pressing on the area can alleviate pain. Activating certain large sensory neurons that deliver messages about touch or pressure can stimulate inner neurons in the spinal cord that release enkephalins. These interneurons inhibit neurons in the pain pathway. Proprioceptors help maintain the position of the body and its part. There are 3 main types. We have muscle spindles, which detect muscle movement, Golgi tendon organs, which determine stretch in the tendons and attach muscle to bone, and joint receptors, which detect movement in ligaments. Thanks to these mechanisms, we have conscious awareness of body position and movement, known as kinesthetic sense. As the sense of smell, taste, sight, and hearing decrease, the risk for accidents increases. Decreased sensations of smell and taste make food less appealing. So as individuals age, their sense of smell decreases, their sense of taste decreases, sweet is the last taste to remain intact, and they have a decreased sense of touch. As previously stated, these things increase the risk for injury and accidents.